Stroke symptoms include trouble speaking, trouble seeing in one or both eyes, headache, dizziness, weakness in one arm, numbness or weakness of face, and trouble walking and loss of balance or coordination. Defined as abrupt onset neurological deficits persist more than 24 hours with no apparent cause other than that of vascular origin, progressing or evolving, completed and transient ischemic attack. TIA clinical syndrome of rapid onset of focal deficits of brain function, which resolves within 24 hours, regardless of whether there is imaging evidence of new permanent brain injury. Progressive stroke, a stroke in which focal neurological deficits worsens with time, also called stroke in evolution. Completed stroke, stroke in which focal deficits persist and do not worsen with time. Risk factors include age, gender, male, race, Asian, hereditary, previous vascular event, MI or peripheral embolism, and high fibrinogen. Modifiable risk factors: high blood pressure, heart disease like atrial fibrillation, heart failure, diabetes, mellitus and endocarditis, hyperlipidemia, smoking, excess alcohol consumption, oral contraceptives, social deprivation, and obesity and sedentary lifestyle. Types of stroke: ischemic 85%, hemorrhagic 5%, and thrombotic and embolic ischemic types, and hemorrhagic 15%, intracerebral and subarachnoid hemorrhages. Pathophysiology: brain requires constant supply of glucose oxygen delivered by blood. Brain receives 50% of resting output and accounts for 20% of total body oxygen consumption. Cerebral blood flow is maintained via autoregulation. Thus, brain is highly aerobic tissue where oxygen is limiting factor. Blood flow: if zero lead to death of brain tissue within 4 to 10 minutes and less than 16 ml per 100 grams tissue, infarction within an hour, less than 20 ml per 100 gram tissue, ischemia without infarction unless prolonged for several hours. Intracerebral and subarachnoid hemorrhages are hemorrhagic type of strokes. High mortality rates when compared to ischemic stroke. Pathophysiology of hemorrhagic stroke: explosive entry of blood into brain parenchyma structurally disrupts the neurons. White matter fiber tracts are split. Immediate cessation of neuronal function. Expanding hemorrhage can act as a mass lesion and cause further progression of neurological deficits. Large hemorrhages can cause transitional burning and rapid death. Intracerebral hemorrhage is a result of chronic hypertension. Small arteries are damaged due to hypertension. In advanced stages, vessel wall is disrupted and leads to leakage. Subarachnoid, most common cause is rupture of sacral or berry aneurysm. Other causes include AV malformation angioma associated with extremely severe headache. Etiology of ischemic stroke: thrombotic, lacunar stroke, large vessel stroke, and hypercoagulable disorder. Embolic: artery to artery, carotid bifurcation, aortic arch, and cardioembolic, atrial fibrillation, myocardial infarction, mural thrombus, and bacterial endocarditis and mitral stenosis. Atherosclerosis is the most common pathology leading to thrombotic occlusion. And lacunar stroke accounts for 20% of all strokes, result from occlusion of small, deep penetrating arteries of brain. Thrombosis leads to small infarcts known as lacunae, clinically manifestation as lacunae syndrome. Cardioembolic stroke: embolus from heart dislodged in intracranial vessels. MCA is most commonly affected. Atrial fibrillation is the most common cause. Others include MI, prosthetic valve, rheumatic heart disease. Artery to artery embolism: thrombus formed from atherosclerosis block gets embolized into intracranial vessels. Carotid bifurcation atherosclerosis is the most common source. Others are aortic arch and vertebral arteries. Ischemic penumbra: tissue surrounding core region of infarction which is ischemic but reversibly dysfunctional, maintained by collaterals and can be salvaged if reperfused in time. Primary goal of revascularization therapy. Signs and symptoms. Examination: neurological examination is highly variable and depends on the location of vascular region. Skin: look for xanthelasma, rashes, and limb ischemia. Eyes: look for diabetic changes, retinal emboli, hypertensive changes, arcus senilis, CVS, hyper or hypotension, abnormal rhythm, murmurs, JBP, peripheral pulses, pulmonary edema and infection, abdomen, urinary retention, locomotor system, injuries sustained during collapse with stroke and comorbidities, History. As per onset and duration of neurological symptoms, completed stroke or stroke in evolution, and history of previous TIA, history of hypertension, diabetes, and heart conditions like arrhythmia, RHD, prosthetic valves, history of seizures and migraine and anticoagulant therapy, oral contraceptive usage, history of any anticoagulable disorders like sickle cell anemia or polycythemia vera, substance abuse like cocaine and amphetamine. Stroke warning signs include sudden numbness or weakness of the face, arm, or leg, especially on one side of the body, and sudden confusion, trouble speaking or understanding, and sudden trouble seeing in one or both eyes, and sudden trouble walking, dizziness, and loss of balance or coordination. Sudden severe headache with no known cause. Right non-dominant hemisphere stroke common pattern, neglect of left visual field, extension of left-sided stimuli, and the left hemiparesis, and left-sided sensory loss, and left visual field defect, and dysarthria, and poor left conjugate gaze, and spatial disorientation. Left dominant hemisphere stroke common pattern, aphasia, right hemiparesis, right-sided sensory loss, and right-sided visual field loss, and poor right conjugate gaze, dysarthria, difficulty reading, writing, and calculating. Clinical localization of stroke syndrome depends on functional anatomy and blood supply, whether it is involving in the motor area or sensory area or frontal lobe or Broca's area or temporal lobe or occipital area or parietal area or Wernicke's area or cerebellum. Blood supply depends on the cerebral artery. This one is posterior cerebral artery. This one is middle cerebral artery. This is anterior cerebral artery. Large vessel stroke within anterior circulation or posterior circulation, and small vessel disease of the vascular bed depends on the classification. Cerebral circulation, anterior circulation include middle cerebral artery, and anterior choroidal artery. Posterior circulation, vertebral, basilar, and posterior cerebral artery. Stroke within the anterior circulation due to occlusion of internal carotid artery and its branches, middle cerebral, and anterior choroidal artery. Middle cerebral artery infarction, clinical features, superior branch, contralateral hemiplegia, face and upper limb more involved than the lower limb, and contralateral hemisensory loss, and conjugate paresis. Patient looks towards the side of the lesion, and Broca's dysphagia if left-sided. Middle cerebral artery infarction, inferior branch, clinical features, contralateral hemianopia, Wernicke's dysphasia, and left spatial neglect. Middle cerebral artery infarction, stem occlusion, clinical feature, contralateral hemiplegia, contralateral hemisensory loss, contralateral gaze palsy, and the hemianopia, and global dysphagia, anosognosia, and altered sensorium due to edema. Next, middle cerebral artery infarction, lenticular striate occlusion, deep penetrating of lenticular striate branches supplies the internal capsule, cardiac nucleus, putamen, and pallidus. Occlusion of lenticular striatal branches produce pure motor or sensory motor stroke contralateral to the side of the lesion. If ischemia of putamen pallidus, main features as Parkinson's features. Anterior cerebral artery infarction features paralysis of leg contralateral with foot with paralysis of arm, and cortical sensory loss over leg and foot, and presence of primitive reflexes, and urinary incontinence, gait apraxia, mutism, delay and lack of spontaneity of motor action, apraxia of left-sided limbs. Anterior choroidal artery supplies post limb of internal capsule, retrolentiform and sublentiform parts. Syndrome, contralateral hemiplegia, contralateral hemianesthesia, and homonymous hemianopia. Posterior circulation supplies cerebellum, medulla, pons, thalamus, hippocampus, occipital lobe, and lesions of the medulla, medial medullary syndrome, ipsilateral 12th nerve palsy, and contralateral hemiplegia sparing the face, and hemianesthesia sparing the face. Lateral medullary syndrome, ipsilateral 10th nerve palsy, and cerebellar signs and Horner syndrome, and impaired pain, temperature, and touch on the upper half of the face, and contralateral impaired pain and temperature over the body. Basilar artery, paramedian wedge of the pons in the midline, and short circumferential lateral two-thirds of the pons, and middle and superior cerebellar peduncles, and long circumferential superior and anterior inferior cerebellar arteries. Basilar artery syndrome, occlusion of basilar artery, bilateral brainstem signs, and occlusion of basilar branch artery, unilateral motor and sensory and cranial nerves, and complete basilar artery occlusion, locked in state, bilateral long tracts, sensory and motor with the cranial nerves and cerebellar dysfunction, preserved consciousness, quadriplegia, and cranial nerve signs will be there. Inferior Pontine syndrome, medial inferior Pontine syndrome, and lateral inferior Pontine syndrome. Medial inferior Pontine syndrome results in corticospinal tract lesions, results in contralateral spastic hemiparesis. Medial lemniscus lesions result in contralateral loss of tactile sensation from trunk extremities. Abducens nerve roots lesions results in ipsilateral lateral rectal paralysis and lateral inferior Pontine syndrome. A facial nucleus and intra-axial nerve fibers lesion result in ipsilateral facial nerve paralysis, ipsilateral loss of taste from the anterior two-third of the tongue, ipsilateral loss of lacrimation and reduced elevation, and the loss of corneal and stapedian reflexes, apparent limbs. Medial Pontin syndrome caused due to occlusion of paramedian and short circumferential branches of basilar artery, corticobulbar and spinal contralateral phase, arm and leg paralysis, and cerebellar peduncles, ataxia of limb and gait. Weber syndrome occlusion of a perforating branch of posterior cerebral artery, ipsilateral nerve palsy and contralateral hemiplegia. Benedict syndrome, ipsilateral third nerve palsy with contralateral cerebellar ataxia. And Perinaud syndrome, paralysis of up and downward gaze and pupillar disturbance, Argyll Robertson pupil, absence of convergence and non-communicating hydrocephalus. So, posterior cerebral present and posterior present. Crossed hemiplegia present and bilateral deficits present and cerebellar signs present, ocular findings present and dissociated sensory loss present. Sensory loss over V1 and V2 will be present, whereas anti-circulation, these are all absent. Differential diagnosis include craniocerebral and cervical trauma, meningitis, encephalitis, intracranial tumor, subdural hematoma, seizures persistent with persistent neurological signs and migraine with persistent neurological signs and metabolic include hyperglycemia, hypoglycemia, post-cardiac arrest ischemia, drug or narcotic overdose. Hypoglycemia cause hemiplegia and aphasia. The wide use of bedside laboratory testing for glucose now makes this easily undetectable. Hemiplegia may resolve immediately with the administration of intravenous glucose, but resolution over hours also is reported. Space-occupying lesions, subacute or chronic duration of symptoms. However, some patients may present with acutely, probably due to bleeding into a tumor and associated with deep-seated bursting headache and projectile vomiting due to raised intracranial tension. Migraine may actually precipitate the stroke, and there is also a variant of migraine, hemiplegic migraine. Investigation to confirm the vascular nature of the lesion and pathological type of the vascular lesion and underlying vascular disease and risk factors. Is it vascular lesion? Is it ischemia or hemorrhage? First, we have to do the CT scan and followed by MRI. Invasive and non-invasive. Invasive is lumbar puncture, CT angiography, and contrast angiography. Non-invasive CT scan, MRI, Doppler, MR angiography, and general investigations like food, blood count, polycythemia, thrombocytopenia, blood glucose, serum lipids, hypercholesterolemia, blood culture, bacterial endocarditis, HIV screening, AIDS, syphilis, VDRL, clotting screen, thrombophilia, protein C and protein S, anticardiolipin antibodies for SLE, and lumbar puncture for subarachnoid hemorrhage. CT scan mandatory initial investigation. Hemorrhage appears initially as a hyperdense area. Infarct appears as hypodense area. Infarct may not appear before 48 hours. And MRI may be done instead, but a CT scan is more sensitive for detecting hemorrhage. And a diffuse weighted MRI is good for identifying ischemic lesion. Subarachnoid hemorrhage and ischemic stroke. CT or MRI vascular nature confirmed. If there is ischemia or hemorrhage, search for the source. And if there is normal CT scan, hemorrhage suspected, lumbar puncture, and CSF with blood xanthochromia, and hemorrhage confirmed. Emergency CT negative shows a subarachnoid hemorrhage. Then refer to neurosurgeon and resuscitate and pneumodependent 60 mg. If there is emergency CT, no subarachnoid hemorrhage, negative for subarachnoid hemorrhage, then CSF analysis after 12 hours. Blood xanthochromia shows subarachnoid hemorrhage. If CT and CSF at 12 hours are negative, then patient not had a subarachnoid hemorrhage. Immediate assessment of airway vital signs and general medical assessment include evidence of injury, or cardiovascular abnormalities and neurological assessment and maintenance of adequate tissue oxygen, protecting the airway oxygen and maintaining optimal blood pressure, auto regulation, faulty or lost in stroke patient. And stroke or a TIA, first you have to see airway breathing circulation followed by glucose and obtain imaging whether the CT or MRI. If it is TIA or ischemic stroke, it is different, and if it is hemorrhage, consider BP lowering, establish aneurysm or hypertension or other cause. BP lowering, ischemic stroke, consider thrombolysis, established cause or thrombectomy, and like atrial fibrillation, carotid disease, these are all like established. Deep in thrombosis prophylaxis, physical or occupational speech therapy, and evaluation rehabilitation will be there. Medical management, if diffuse atherosclerotic disease or poor operative candidate, stop smoking, and the current medical problems should be addressed. Emboli from heart and other cardiovascular system, anticoagulants like heparin or warfarin, antiplatelet like aspirin, ticagrelor, diabetes, hypertension, hyperlipidemia management, airway breathing, circulation, nutrition, hydration, and transient ischemic attack, surgical management, carotid cerebral arteriography. There is stenosis, mild to moderate regular follow-up. There is severe stenosis, carotid endarterectomy. Blood pressure, unless indicated, heart or renal failure, hypertension, encephalopathy, or aortic dissection, it should not be lowered for the fear of expansion of infarct. Ischemic stroke, maintain 180 by 110. Hemorrhagic stroke, keep mean arterial pressure less than 115 millimeter mercury. Blood glucose, insulin to treat hyperglycemia, increase the infarct size, maintain less than 200 milligram percent. And temperature, early use of antibiotics and pressure areas to prevent occurrence of decubitus ulcer and incontinence. So act fast at the first sign of stroke. If there is face weakness, arm weakness, speech difficulty, or loss of balance, time is free. Ischemic therapy, thrombolytics, ischemic stroke, thrombolytics or revascularization, antiplays 0.9 mg per kg, maximum 90 mg, 10% of dose initial IV bolus, and the remainder infused over 1 hour to be used less than 3 hours of onset of symptoms, and hemorrhage should be ruled out, and neuroprotective agents like given. And antiplatelet therapy, aspirin, clopid act by inhibiting platelet aggregation and adhesion, and aspirin 300 mg single dose given immediately following diagnosis, and if antiplace given, it can be withheld for 24 hours. Later, aspirin at a dose of 75 mg in combination global 75 mg daily for about 1 year duration can be given. And anticoagulants, heparin acts by accelerating inhibiting factor, inhibition of factor 2 and factor 10 of coagulation cascade. Warfarin antagonizes the vitamin K to prevent the activation of coagulation factors. Decrease the risk of recurrence and venous thromboembolism. Intracranial hemorrhage to be excluded before the therapy. Now, hyperosmolar reduce the cerebral edema, 20% mannitol IV, 100 ml TDS, oral glycerol solid is normal. Concurrent medical problems such as atrial fibrillation to be tackled, and others like pentoxypyllin to be used within 12 hours, and neuroprotective agents. Hemorrhagic stroke, control of hypertension, control of coagulation abnormality due to oral anticoagulant, surgical decompression, surgery for aneurysms and arteriovenous malformation, antiplatelet and anticoagulants are contraindicated. Platelet and anticoagulants are contraindicated. Secondary prevention, blood pressure control, diabetes, lipid management, smoking and alcohol control, weight reduction, cardiac artery intervention, antiplatelets, statins, and diuretics are ACE inhibitors. And physiotherapy as early as possible, speech therapy, occupational therapy, improve the quality of the life, and leg brace and the sinus process. And poor prognostic factors in stroke, accompanying fever, hypotension, low oxygen saturation, hypoglycemia, spontaneous hemorrhage, low GCS score, heart failure, and severity of hemiparesis. Complication of acute stroke, chest infection, and epileptic seizures, deep in thrombosis, painful shoulder and pressure sores, urinary infection, constipation, and depression and anxiety. Prognosis, ischemic stroke mortality rate in first 30 days is 8 to 12%, can vary depending on size, location, symptoms of stroke. Time that elapses from the event to medical intervention, first 3 hours of the stroke are golden period. Intracerebral hemorrhage mortality rate is in first 30 days is almost 50%. Site and extent of hematoma also play a role in determining prognosis. Hemorrhagic strokes have poor prognosis compared to ischemic stroke.
If you are in discipline, you are a slave to your moods. You are a slave to your passions. Only the disciplined ones are free in life.